Okay, good afternoon, everyone. Thank you very much for coming today. Really keep up the strong in-person attendance. It sounds like we're ahead of the game. A lot of places are still on Zoom, so we appreciate you making the effort to come in person. And today is a very, very special presentation, and I'll share a few words as to why it's so special. So I bet a lot of you have heard this new term of quietly quitting at work. How many of you are familiar with this term? Raise your hand. Quietly quitting at work? Yeah. So this is something that we hear a lot about, that people are sort of taking a back seat, especially after the pandemic, disengaged, not that excited to contribute. But that's not the way you would describe our speaker today. And I get a chance to actually be on many Zoom meetings with Elaine, and I'd say it's completely the opposite. And it's really inspirational for me to work with someone who continues to give it her all after being on faculty at the University of Chicago for over 20 years. So a little bit about her. So as I mentioned, she's been at University of Chicago for 2 decades, and over that time has dedicated her research activities to understanding the pathophysiology of kidney stones in humans. And there's very few people who do this really well, who study physiology in patients to help us understand how to manage our patients. And over her career, she has uncovered a lot about what are some of the mechanisms of idiopathic hypercalciuria, how acid-base abnormalities contribute to urinary calcium loss. She's also studied the links between kidney stones and chronic kidney disease, urinary crystallization inhibitors, and more recently, the effects of age and gender on how the kidney handles acid load and excretes minerals. And over this career, she has also been incredibly collaborative and has worked with urologists and leads currently the program project that is with urologists at Indiana University. As I mentioned, I'm inspired by Elaine and our collaboration now in the context of a training grant, but I wanted to mention a couple of things, Elaine, that maybe you don't know, and that is when I was first starting out my own research career, there was a paper that Elaine lead authored in the American Journal of Physiology in 2007. That was on postprandial reduction in renal calcium, and I have read that paper a million times, and it helped me advance my own career. And then in the clinical realm, there's a paper that I would highly recommend that our fellows read, and that's a paper on stones from bowel disease, actually published in this obscure journal, Endocrinology, Metabolism and Clinical North America. I think it should be published in the Renal Journal, or we should invite you to publish on this topic again in the Renal Journal, but it's kind of a very high relevance for those of us who treat patients with ulcerative colitis and Crohn's disease who develop kidney stones. And so really, there is many more papers that have had an impact on both research and clinical care, but those are the two that I would point out today. And finally, I would just say she continues to be a tireless advocate for fellows and those interested in research, including women. And I, again, as in my interaction with her with the training grant, I see that every time we have a call together. And for these activities, she has received the Nephrology Section Mentorship Award, and she's going to be recognized at the ASN. So if you're at the ASN this year, there's going to be a very special lectureship, the Jack Coburn Endowed Lectureship. So if you're there, I think it's Friday morning, please be sure to stop by. So Elaine, thank you again, and we look forward to your talk.
Thank you so much for that very warm welcome. I'm blushing. I'm probably bright red. So I wanted to talk to you today about some of the work that we have been doing over the last 20 years at the Stone program at the University of Chicago. As Tamara said, the work we've done has been aimed at a better understanding of the causes of stone disease, but we have also learned a lot about physiology that applies more generally. I want to talk to you a little bit about a couple of the studies that we've done that I think apply to general physiology. But I also want to spend a little time talking about the way the epidemiology of stone disease is pointing us towards the fact that stones may be a manifestation of a really more generalized metabolic derangement, and that stone formers have a lot of other comorbidities. They are at high risk for other bad outcomes, and that is why I called it Canary in the Coalmine, because I think stones sometimes get passed off as just a minor inconvenience, or maybe not so minor if you don't like pain. But the truth is, I think they are sometimes a warning of people who have sort of derangements that have yet to produce bad outcomes, but they are at high risk, and I want to highlight that. So this is the epidemiology of kidney stones, and this is drawn from NHANES, which is the National Health and Nutrition Examination Survey. And they do these in waves, and they've been asking questions about kidney stones for quite a while now. And so you can see maybe the earliest wave was back in the late 70s, and at that time the overall prevalence of kidney stones in the United States was about 3.2%. And in this figure, it's this sort of like dark band that represents that wave. And you can see certain features that are true, which is one is that stone prevalence rises with age. It's a bit more prevalent in men than women, although the difference is shrinking. And it's more common among whites than blacks. But in each subsequent wave, you can see the prevalence has been growing, and that this increased prevalence is occurring at all ages, in both sexes, and in all races. So this is a generalized increase in the prevalence of stones. And I would say our work that I'm going to be telling you started around here. And now the last two waves are showing us that the current prevalence of kidney stones in the United States is about 11%. And what that means is that if you're in a high-risk group, like white men, your prevalence is up here somewhere. You're off the charts. We know that stone disease has a fairly high genetic component, and twin studies suggest that the heritability would be about 45%. And this is leaving aside, there are some people with monogenic diseases like cystinuria, primary hyperoxaluria, but I'm really talking about idiopathic stones. But they have a fairly high heritability. But this kind of change over 4 decades is clearly environmental. And here's one other fact that may be related, and that is that the prevalence of obesity, defined as a BMI of greater than 30, has also tripled over that same time period, so that while stone disease was more than tripling, so was obesity. And I'm going to argue that those two things may be related. So I'm going to be showing you some data from our work in the Clinical Research Center at the University of Chicago, and I thought I would just give you some information about how this protocol was run. And we have recruited calcium stone formers with idiopathic hypercalciuria who did not have systemic disease or diabetes or illnesses where they had to take medications that could not be stopped. And we also recruited age and sex matched healthy non-stone formers as controls. If they were taking medications for stones, we asked them to stop it for about a week prior to the study, and then they would, and we would have a dietitian who would advise them on their diet and ask them and counsel them and try to get them on our diet at home for about the prior week. And then they would come to the CRC in the morning, and we would collect hourly bloods and urines on a schedule like this. So we would see, we would collect fasting bloods and urines, and then we would feed them 3 meals and collect bloods and urines throughout that time period. And overall, we've had 77 subjects completed the entire protocol. Some were studied twice. This was our diet. And it was, as you can see, it was had a normal, pretty generous calcium content and relatively low sodium content. And this is based off of a diet that was actually used in a trial that was shown to actually be beneficial in terms of preventing recurrent calcium stones, a generous calcium intake and a low salt intake. And it was devised by dietitians so that the nutrient balance between protein, carbs, and fats is what's recommended. And this is the demographics for the group that I'm going to be showing you data about today. The controls and the patients, the ages are basically, late 30s to 40s. Their BMIs tend to be a little generous, but they're not basically obese, although there's a very wide range. So here's one other piece of epidemiologic data that's interesting about stones. Calcium oxalate stones, as we know, are the most common type of stones at all ages and in all prevalence. This data comes from Mayo Clinic, where they have analyzed many, many thousands of stones. And when you look at the distribution over age and sex, calcium oxalate is by far the most common. But the other two most common stone types, calcium phosphate and uric acid, show sort of an interesting pattern that changes with age. And you'll see that calcium phosphate stones are most prevalent at younger age, and particularly in younger women. They rival calcium oxalate stones, but then they begin to decrease in prevalence. And at older age, we see this rise in uric acid stones, again, in both sexes, so that the prevalence of these stones is very highly age-related. Now, if you know anything about stones, you know that supersaturation is probably the concept that we teach, which is, if you're going to make a stone, the only way to make a stone is to have urine that's supersaturated with the mineral. And for calcium oxalate, pH doesn't matter, but for uric acid and phosphate, pH matters a lot. Now, this is data on urine pH that's from the University of Chicago Stone Lab. And these are normals, like many, many, many hundreds of just everybody, normals and stone formers. And what you can see is that the median pH falls about 6. And here is supersaturation. A 1 indicates a urine that's exactly at thermodynamic solubility for that substance. If it's above 1, the urine is supersaturated. Under 1, it's undersaturated, and a crystal would dissolve. So what you can see is this sort of cloud here represents the supersaturation of a given urine for uric acid. And what you can see is as the urine pH falls below 6, supersaturation rises very dramatically. But then as the urine pH goes the other way, if it goes above 6, supersaturation falls, and the urine becomes very rapidly undersaturated for uric acid. Calcium phosphate is the exact opposite. If you have an acid urine, calcium phosphate is very soluble, and as the urine becomes more alkaline, calcium phosphate becomes supersaturated. And so this suggests, so we know that pH drives the supersaturation of these salts. And so we were very interested in, acid-base changes in patients and controls. But one thing we noticed as we were studying this, which we had not actually predicted, was that there was a systematic difference in the urine pH of normal men and normal women. And this is a study from 7 men and 7 women, but we've replicated it in the larger population. And here's the fasting urine pH and the fed urine pH. And you can see that, urine pH is lower when you're fasting and rises when you eat, but that either fasting or fed, the urine pH of women was significantly higher than the urine pH of normal men, whether fasting or fed. And this was highly significant. And we found that it was because women tended to absorb more alkali from their diet. We were feeding them the exact same food. And women just absorbed more alkali, and during the fed period, their urines became alkaline and their net acid excretion went to 0. in looking at the literature, it turned out that there had been some data about these differences in urine pH between men and women, but they'd really been attributed to differences in the way people eat, that women just eat a more, I guess, leafy green diet, and men tend to eat the meat. But here we were feeding them the same, so it wasn't because they were choosing different foods. So we thought, this is actually very interesting because this might be a very good thing to do if you're a woman who is going to be making a skeleton of a baby, because having that alkali would help you stabilize and preserve a skeleton. So we thought that's a very useful thing to do if you're a young woman of childbearing age. But we thought, well, that might mean that maybe this goes away. At menopause, you wouldn't have to do this anymore, so maybe the whole thing stops at menopause. So we were fortunate enough to get a large data set from Litholink, from John Asplin, who's here in the audience. Litholink does 24-hour urines for stone formers nationwide. And so we were able to get 24-hour urine data from almost 8,000 stone formers, a much bigger population than we could have done locally. And so we were able to see what happened to the urine pH of these stone formers with age. And to our surprise, women were higher throughout the lifespan compared to men. But everybody dropped with age. Everybody's pH dropped as they got older. It's just that the women were always higher than the men. And we thought, well, what could this be from? And, so we looked at adjusting the pH for everything we could think of that we could learn from the data that would affect urine pH. So we adjusted for GI anion, which is the alkali you absorb from your diet, and this is actually the formula that you use for calculating that. You use urine electrolytes to calculate this. And it has a very high F value. It's very significant. We corrected for urine sulfate, which is the residue of the acid load from our diet. We corrected for BMI, for age, for sex, for renal function, and for, oh my goodness, what is this? Now I've messed this up. But anyway, with all our corrections, this is the corrected data. And so what the correction did was it actually collapsed the difference between the men and the women, but it did not get rid of this fall with age. And I will also point out that it's interesting, this flattens as you get older, and the reason for that is because the absorption of GI anion rises with age. So this left us with a problem of what is going on here, and we thought, is it possible that acid production is rising with age? We know that the conventional equation for acid excretion, which we're all familiar with, is ammonia excretion plus titratable acidity minus bicarbonate. Now, on the other side of this, if you're going to be in balance, is acid production. And acid production is accounted for by sulfate, which in other words is dietary sources of acid, and GI anion, which are dietary sources of alkali. But there's a third term, and it's organic acid, and it's from metabolic production. Now, the fact that this and this basically have to be in balance has been validated using balance studies, which were done maybe 50 years ago by Jack Lemmon, who was a very, very excellent nephrologist and physiologist, who I was lucky enough to be able to work with toward the end of his career. And he did balance studies that were able to show that there is, balance between these two sides of the equation. But, balance studies are really time-consuming and expensive and hard to do. You can't do a lot of them. And so he really concentrated on, a small group of healthy people, mostly young men, so that we really couldn't say anything about whether there were changes with age or with sex. So we actually set up the method to do this organic acid. And this is not something you can do with an ordinary 24-hour acid. You actually have to titrate this in the lab. You have to set up titration equipment to detect this. And we have had a number of students who've worked with us over the years who've worked very diligently on this. And this is actually the result of this. And what we found was that using this titration, the same method that Jack Lemmon used, there is, in fact, we could detect an increase in these organic acids with age. There's a significant increase in this organic acid production with age in both sexes, and it's in stone formers and in normals. And so it suggests that there is some kind of acid stress that occurs as people age, and there's been other, work to suggest this. What these molecules are, we do not know yet, but they would presumably be, like part of the Krebs cycle intermediates, for example. And I'm going to suggest that if you want to know more about this, this is going to be presented at the ASN on Saturday morning, and our students will be there to talk to you about this work if you're interested in hearing more about it. So I want to move to more of the issue that we started off addressing, which was urine calcium excretion. And again, as I said, urine supersaturation is the key to stone formation. This is data taken from the Nurses' Health Study 1 and 2 and the Health Professional Study by Gary Curran, working with Megan Prohaska. And you can see that your risk of making a stone was very strongly related to urine supersaturation, in this case calcium oxalate, and also for calcium phosphate. It's true across the board. And urine calcium and urine oxalate are both important drivers of that supersaturation. So, we've always been very interested in the notion of what is it that causes idiopathic hypercalciuria. We know that there is a strong genetic component, and this is data from Kristen Bergsland from the time when she was working at Litholink. Again, this was a study done there. And they recruited children who were stone formers, who made calcium stones, as well as their non-stone forming siblings and normal children of the same age and sex. And what I would show you is these are the urine calcium excretions in the stone forming children. And it turns out that they were, depending on the more stones you made, the more hypercalciuric you were. And these are the normal kids, but the siblings who did not make stones were still hypercalciuric relative to the normal kids. So there's clearly something genetic driving this abnormality, although there are strong environmental influences as well. And idiopathic hypercalciuria is not just a risk factor for stones, it's also a risk factor for bone disease. And that's because, interestingly, these patients tend to be in negative balance for calcium. And this is also data that comes from a number of balance studies, some of them done by Jack Lemmon, some by many other people. And this is basically a plot that shows the relationship between the amount of calcium absorbed from your diet, from the gut, and the amount of calcium lost in the urine. And what you can see here, this blue ellipse and all the little blue dots, are from normal people. And this line is the line of identity, which means that this would equal this. The amount you absorb is pretty much exactly what you put out in your urine. And you can see that normal people kind of distribute around the line of identity so that on average, the amount of calcium absorbed equals the amount excreted. But the red, these are patients with idiopathic hypercalciuria and kidney stones. And you'll notice two things, or at least two things. One is their urine calciums are much higher, ergo idiopathic hypercalciuria, and their absorption is shifted over here to the right. But this line of identity does not run through the middle of this ellipse. Instead, many of the points are here on the left side, which means their urine excretion is higher than their absorption. They are in negative calcium balance, despite the fact that they absorb generous amounts of calcium from their food. They have some defect in the ability to reabsorb and retain calcium, and therefore they develop bone disease and fractures as well as stones. So this is data taken from, the many patients that we studied over the year, calcium excretion and calcium stone formers. And this is displaying the data. The red is women, the blue are men. The hatched are from stone formers, and the solid are from the normals. And what I'm showing you here is their urine calcium excretion per hour in the fasting period, in the fed period, and overnight. And what I really want to draw your attention to is the fact that the stone formers are higher all through the day, not just when they eat, but fasting and overnight at a time when most people's urine calcium falls dramatically. And we also did endogenous lithium clearance, which tells us something about proximal tubule. And we know that the proximal tubule tightens up at night. You're not eating, you're not taking in any fluid, and your proximal tubule starts to really reabsorb salt and water, and along with it, calcium. So much less calcium leaves the proximal tubule, and so for most people, they're excreting less calcium along with less salt. But the stone formers continue to, and their proximal tubules tighten up as well. They're not any different. Their salt handling is exactly like the normals, but their calcium handling is not. And so all night long and during the fasting period, they're excreting calcium, and this is their fractional excretion of calcium, which is higher during that fasting period. Now, this is not a general phenomenon. They can handle magnesium just fine. This is magnesium reabsorption. They're not hyper-excreting magnesium, just calcium. Now, the other thing I want to show you is this. This is what happens when we feed people. We see a big increase in calcium excretion in the normals and in the stone formers. And here you see this. This is the kick up here in calcium, and you see it in magnesium. Everything rises. And this is comparing the normals and the stone formers. And this rise is pretty similar in everybody. Here the normals and the stone formers look pretty much the same, although the male stone formers may be a little bit more than the normal men. But this is a phenomenon that affects everybody, everybody seems to suddenly start excreting calcium when they eat. So you would think, well, that's pretty normal. I mean, you're feeding them calcium. You showed us what's in the diet. Of course they're going to excrete it. They're absorbing it. They'll excrete it. And that is true. But here's something else that sheds a little different light on it. And this is, again, a study from Jack Lemmon, which was published about 50 years ago. And what it shows is what happens when you feed people, either normal people or stone formers, just glucose or sucrose. You're feeding them nutrient, but you're not feeding them any other substances along with it. And what he showed was if he gave them glucose or sucrose, whether they were normals, whether they were stone formers, or the siblings of stone formers, everybody's urine calcium suddenly went up. And there's actually other investigators that did this. And here, this is essentially a dose-response curve. And you can see the more sugar you give them, the more their urine calcium rises. And you see exactly the same phenomenon with magnesium. So what this means is you don't need to feed them any calcium. You just need to feed them a nutrient like sugar. You can see it with glucose or sucrose. You can see it with amino acids as well, with protein like amino acids like tryptophan. So there's a response to nutrient of increased calcium excretion that does not require calcium ingestion. And there was an interesting paper that was published a few years ago that showed that glucose is a positive allosteric modulator of the calcium sensing receptor. Now, this was basically done in vitro. But we thought this was very interesting, and in light of this, we thought this may have something to do with the effect we're seeing here. And so we kind of repeated Jack Lemmon's experiment using 6 normal, healthy people. And what we did was basically bring them to the CRC. We collected fasting urines and bloods, and then we gave them 100 grams of glucose, like a glucose tolerance test. And so here's the baseline, the 3 fasting periods. And here's what happens when you feed them the glucose. So their serum glucose rises. These are 30-minute periods, so the serum glucose rises over about an hour. The serum insulin rises, as you would expect, during the same. And these are the periods that are significantly different from baseline. The fractional excretion of calcium and of magnesium both rise right along the same thing. And interestingly, the serum PTH falls when the glucose rises. And we actually see this again with nutrient, that the serum PTH falls during that post-nutrient period. We also measured the abundance of some exosomes in the urine, which allow us to quantify certain transporters. And we found that TRPV5, the transporter for calcium in the distal nephron, also falls in the post-glucose period, though we didn't see any change in transporters like NHE3, NCC2, or the sodium chloride cotransporter. So what's going on here? Well, here's what we think. This is the way we put this together. This is a phenomenon in which calcium and magnesium essentially rise together. If you plot them against each other, they're basically linearly related. And so whatever's happening, it's happening at a site in the nephron that's affecting both the calcium and the magnesium. So where could this be? Well, our nomination is for the thick ascending limb. And that's because at that site, calcium and magnesium reabsorption are both controlled by the calcium sensing receptor. Calcium and magnesium are both reabsorbed paracellularly, and there is a sort of gating function here controlled by claudin 16 and 19. And claudin 14 is a further control element which can block the effect of claudin 16 and 19 and increase excretion of magnesium and calcium. And this claudin 14 is under the positive control of calcium sensing receptors. So when calcium sensing receptor is stimulated, you get upregulation of claudin 14, which blocks this. It also is under control of PTH receptor, which is a negative. But if your PTH drops, then this negative would be reduced a bit, same effect. So that the stimulation from lower PTH or higher calcium sensing receptor would tend to lead to an increase in both calcium and magnesium excretion. You won't see this at either proximal tubule, where magnesium is not absorbed very well. And you really wouldn't see it in the distal nephron, where calcium and magnesium are both actively reabsorbed, but the two transporters are under different control mechanisms. And we felt that the drop in PTH from calcium sensing receptor in the parathyroid gland and the effect on thick ascending limb both tended to suggest that this effect is mediated through calcium sensing receptor. So that's our story, and we're sticking to it. And I will just add a couple of things, one of which is that there was just a recent paper published that shows an association between added sugars. So not the sugars that are naturally present in food, but added sugar, like glucose, fructose, and increase in stones from NHANES. And this was just published this year. And I'm just going to show you quickly what happens when you treat people with thiazide. We know that thiazide will decrease urine calcium excretion, and that's mainly because it causes increased reabsorption in the proximal tubule. So these were these were 4 men who we studied in the CRC on thiazide for 6 months and off thiazide. And you can see that on thiazide, here's the open symbols. And when they were on thiazide, both the fasting and the fed sort of moved back. Their urine calcium's diminished. But that nutrient effect was undisturbed. You see the nutrient effect even with the thiazide. It starts from a lower baseline. So overall, I think the suggestion is that this may be a phenomenon that is worth knowing about in terms of how calcium gets into your urine. So I want to shift gears a little bit here for the last piece of the talk and just talk about recent epidemiology that suggests that stone formers are at risk of increased amounts of cardiovascular disease. This was probably one of the first papers that really demonstrated this. This is from 2010. And this is a study from Mayo Clinic looking at the Rochester Epidemiology Project. And they followed patients for a mean of 9 years. And this is something like 4,000 stone formers and 10,000 controls. And you can see that the stone formers had a much higher incidence of MI over this follow-up period compared to the controls. The mean age of these people was about 45. And you would say, well, okay, we know that stone formers have an awful lot of comorbidities, and you'd be right. Here is study data from about 3 more large cohorts, one from the United States, one from Canada, and one from Taiwan. And they certainly found that the stone formers had many more baseline comorbidities, more likely to be diabetic, more likely to be hypertensive, to have obesity, dyslipidemia, and so forth. But even using multivariable adjustment, they still found an increased risk for MI in the stone formers in all 3 cohorts, with a hazard ratio of about 1.4 in all of them. And they all showed a more increased risk in younger patients, and 2 of the cohorts found an increased risk in women. And this is data from the largest cohort, the Canadian cohort. And what you can see is that these hazard ratios, when you break them out by age, the younger you are, the higher your relative risk, and that the relative risk was also higher in women. So these are a particularly high-risk group for these kind of comorbidities. And further prospective studies have shown that they are at risk for development of a number of other cardiovascular diseases, like ischemic CVA, hypertension, end-stage renal disease and CKD, and atherosclerosis. And most of these studies again pointed out that it was younger people and women who were the highest risk. And I want to just say that a common factor that's uniting the risk for stones and cardiovascular disease is the presence of obesity and metabolic syndrome. We often notice that our stone formers are a bit heavier than the average patient population. And many of them have certain features of metabolic syndrome, which is defined as having 3 or more of these factors: truncal obesity, so not just obesity, but truncal obesity, elevated waist circumference, because it's the abdominal fat that's very metabolically active. Also, elevated triglycerides, low HDL, hypertension, and a fasting glucose greater than 100. And we know that obesity, again, this is from the Nurses' Health Study and Health Professional Study cohorts, that obesity, whether defined by BMI range or by waist circumference, is associated with a very increased risk of stone formation in men and in women. And again, in the Health Professional Study, there was one other very interesting finding, and this was that having kidney stones increased the risk of developing type 2 diabetes. It wasn't just that stone formers were more likely to have it. In this cohort, they studied stone formers who did not have diabetes and followed them along, and they found that the risk of developing diabetes was elevated in all 3 cohorts, in the older women, in the younger women, and in the men. And this persisted even after multivariable adjustment for many factors, including use of thiazide diuretics, as well as intake of a number of dietary elements, including sucrose. So thinking about this, it suggests that being a stone former may be associated with subclinical insulin resistance and abnormal glucose metabolism, and that would have some implications for our treatment of these patients. And so we decided to go back to our cohort and take a look at them and see if we could find any signs of insulin resistance. So to do this, we used what's called the homeostasis model assessment of insulin resistance, or HOMA-IR, which is a sort of a conventional way of assessing insulin resistance. And to calculate it, you take a fasting blood glucose and a fasting blood insulin and create a ratio and divide this by 405. And there are many ways of interpreting this, but this is a fairly conventional one. Less than 1, HOMA-IR less than 1 means you are insulin sensitive. This would be optimal. Between 1 and 1.9 would be okay. Above 1.9 would indicate early insulin resistance, and above 2.9 would indicate significant insulin resistance. We also looked to see if our patients would meet the criteria for prediabetes, which is defined as a fasting blood glucose between 100 and 125. Now, we had 2 to 3 fasting blood sugars for every patient, and we used the mean for that assessment. And this is the preliminary data. This is a study that was actually done by some students working with us over this summer, so we are still in the process of really analyzing this. But what you can see is it does look like a significantly higher number of stone formers had a fasting sugar greater than 100 than compared to their controls. There was a significantly higher number who seemed to have prediabetes by that definition. Their serum glucose was significantly higher in the fasting period, and it was also higher fed. Their serum insulins were significantly different, and the HOMA IRs were significantly different. The HOMA IR of our controls, the mean was 1.4, whereas the mean in the stone formers was 2.3, which would put them into a risk category. I should say glucagons also differed. And here's what you see if you plot the HOMA IR against BMI, and the controls are here in the blue and the stone formers are in the red. And you can see there is a definite relationship in both populations of HOMA IR against BMI. The higher your BMI, the more likely you are to be insulin resistant. But it looks like there's a slightly higher slope in this stone former population. I will say the P is 0.08, so it isn't quite significant. But you can see how many of these stone formers appear to have, HOMA IRs that are clearly abnormal, even at, BMIs that are not, frankly, morbidly obese. Meanwhile, out here, here's a morbidly obese control. This HOMA IR isn't that bad. So I think this suggests that there really may be something going on in our stone formers. And I want to say, if you Q-plot this, you see that what looks like two populations. So there are some stone formers that seem not to have this, but the stone former population is enriched in people who have this. It's not that they all have it, but the population seems to be enriched in people who have it. So I'd like to just draw together this talk with several conclusions to take you back over what we've covered. So one is the prevalence of kidney stones has risen dramatically in the last 4 decades, and this clearly has to be due to environmental causes. The prevalence of calcium phosphate and uric acid stones change with age, and this may be related to the fact that there are changes in acid-base metabolism that track with age as well. Idiopathic hypercalciurics have decreased renal calcium reabsorption that's present all day long, 24 hours a day, and nutrient intake leads to a coordinated increase in calcium and magnesium excretion in all subjects, which we propose may be due to calcium sensing receptor signaling. And stone formers are at an increased risk of cardiovascular disease and diabetes, and the young female stone formers may be at the most high risk. And that some of our patients have insulin resistance, a component of the metabolic syndrome. So how does this imply, what implications does this have for our treatment? Well, certainly I think it has some implications for dietary recommendations. The conventional dietary recommendations for stone formers would clearly still be true: more fluids, less salt, adequate amount of calcium. But one thing we have never really stressed is sugar, and I think we may need to start talking more about sugar with our patients. Americans eat an average of 17 teaspoons of added sugar every day, not just the stuff that's present like in fruit or milk, it's the added sugar. And this sugar is also associated with a risk for cardiovascular disease. So to the extent that sugar is worsening their stones and worsening their risk for cardiovascular disease, we should be talking to our patients about this. Another thing is we may want to use the DASH diet. The DASH diet is known to be helpful for prevention of hypertension. That's why it was invented. and it's associated with decreased risk for cardiovascular disease, but also decreased risk for stones. And it clearly, de-emphasizes things like sugar-sweetened beverages and sweets of all kinds, as well as salt and fat, and emphasizes foods that have more nutritional value. And lastly, I want to say that this probably means we ought to be aware that our stone formers are carrying some added risk that they may not be aware of, particularly younger patients, particularly women, and that as nephrologists, this sort of falls right into our sweet spot, and we should be aware that they need to have their blood pressures monitored, and maybe we should consider monitoring for prediabetes in these patients. Because we're going to find it, I think. And I want to say thank you to my many, many collaborators, particularly Fred Coe at the University of Chicago, who founded the Stone Lab there, Megan Prohaska, my colleague, funded on a K Award. The two students are going to be presenting at, who did the sugar work, and Priya and Yasin, who are presenting at ASN, also John Asplin, and our collaborators at Indiana University. Thank you. Yes. Thank you. Oh, okay. Well, Dr. Bacci is suggesting that the sodium glucose cotransporter inhibitors might be have a role to play, and that's a really, really interesting question. I know of one study where they looked at the effect of the SGLT2 inhibitors on 24-hour urines. They compared baseline excretion with the 24-hour urines after they'd been on the medicines for about a month. And these were normal people. They weren't stone formers. They weren't diabetics. And what they found was there was no change in their calcium excretion. What there was an increase in their urine citrate and a decrease in their urine pH, so that the calcium phosphate supersaturation dropped. So I don't know of any studies in stone formers per se. I've seen some epidemiologic studies suggesting that people who are on SGLT2 inhibitors have fewer stones, but those are not trials. But I think that's a really interesting question. We haven't studied children. Yeah, no, I mean, you're right. And I mean, children are so interesting and so different from adults. They're building skeletons, and, they're really a different whole physiologic thing. But no, this would only pertain to adults. Any other questions? Yeah. Yeah, that's a very interesting question, whether they're, is it genetically based? Is the predisposition for stones and cardiovascular disease come down to the same genes? I am only aware of one study that has asked this question so far. And I do not believe they found that it was the same that the same mutations were linked to both. But it's just one study that I know of so far. Very interesting question. The question being whether the glucose would produce, augment these acids, and whether it's a gut microbiome issue. We have not done either of those. I think that's a very good suggestion. Gut microbiome may well be involved here. I don't know. Yeah. Yeah.
Thanks very much, Elaine. That was really terrific. How much of kidney function and decline in kidney function over time with age contributes to some of the findings?
So we did adjust we think we actually had creatinine clearances, and we adjusted. The F value wasn't very high. It contributes modestly, but it wasn't a big contributor. So I know that there is now, emerging evidence that, there's rising, the rising prevalence occurs in children too. They're getting idiopathic calcium stones, and there are many publications multiple publications showing that they have decreased bone density compared to uninvolved kids. I don't know if there's any actual recommendations, but I know that there probably is and even if they're not accruing skeleton during these years when they ought to be. They will, during their peak bone-making years, they're at risk. But I'm not aware that there's any recommendations, but it seems like a good idea. Yeah.
Thank you for that next presentation. In the population study that you showed that there was increased incidence of stone, did the investigators look at calcium, vitamin D, and vitamin C intake that probably has risen over the years?
So the people who have looked at that are not in the NHANES, but rather in the nurses' health study and in the health professional study. The work that's been done at Harvard by Gary Curhan. And to tell you the truth, I know he has looked at that, and I don't want to quote it because I'm not sure I could quote it accurately. John, you may actually.
You always adjust for vitamin D intake. He's looked at vitamin C, and as you increase your vitamin C intake, stone risk does go up. He doesn't know the stone type, so he only knows the stone phenotype. So the definition, presumably.
Yeah, I mean, if there are many papers from that group looking at these, components of diet, and yes, when they look at this, they have lots of dietary information, and they correct for all of that. So there's a wealth of information there, and I'm maybe just direct you to that literature because it's pretty good.
Thank you very much.
Thank you.